Okay, well, this is my conflict of interest. I do get some grants from a biomed, and I will be presenting a case for you here that has some relevance to the Impella device. So if you want to know about all my disclosure, you can go to our webpage, mcrfmd.com, and I'm heavily conflicted. That's all what I can say. All right, so let me, first of all, let's go ahead and talk about a little bit about cardiogenic shock. I'm going to be presenting one case for you, and it's in the setting of acute MI, cardiogenic shock, stent thrombosis, and how did we manage that case. So again, I think we can all agree about cardiogenic shock, the way we define it: persistent hypotension, less than 80 millimeter of pressure. It is for about 30 minutes at least. Then you have a cardiac index, usually less than 1.8. Tissue hypoperfusion is very obvious with oliguria and cold extremities, mental confusion, and of course an increase in the left ventricular filling pressure. So when you look at cardiogenic shock in MI, it all starts with some stunning or necrosis to the myocardium. Then you get a really vicious cycle. You end up with reduced cardiac output, stroke volume. You end up with reduction in coronary perfusion. This leads to an increase in the left ventricular end diastolic pressure, which again lead to more reduction in coronary perfusion. The wall stress significantly is increased. Myocardial oxygen demand is significantly increased. Of course, the LV function worsen even further. Lower cardiac output, again, more hypotension, and the cycle repeats itself. And I think the most important thing, if you want to take anything out of this slide, is the duration and severity of the shock determines the outcome. And really, the best window of survival is in the first hour. And if you look at this and you say if our door-to-balloon time for an acute MI is 90 minutes, I'll really challenge the audience here to say that this should be reduced even way further, if we have a patient with cardiogenic shock, because every minute counts, and there will be a point where the left ventricle is irreversibly going to be non-functioning. So usually we try to, if we have the opportunity, definitely try to between 30 minutes to 1 hour is when we try to revascularize those patients. Again, this is the case: an 88-year-old female, hypertension, hyperlipidemia, had a stroke, history of carotid endarterectomy. By the way, this is one of our younger patients, 88, and we don't see them younger anymore, except for a couple of cases. Presented initially with a non-STEMI, underwent treatment of her left main, LAD, and circ. She really did not want the CABG. We do follow the guidelines of a heart team approach. Surgeons talked to her. She was not interested at all in pursuing CABG. So she ended up getting a drug-eluting stent, and this happened under intra-aortic balloon support. Her RCA is chronically occluded. At that time, her left ventricular function was normal. So following this, she developed bowel obstruction a few days after her PCI, just to make it very exciting, and required an emergency exploratory laparotomy on Plavix and aspirin. And I don't see too many surgeons who are willing to do this. In her case, our surgeon said, keep the Plavix and aspirin. We have a left main stent just put in a few days ago. So a few days after her surgery, and while in the hospital, she develops an acute anterior MI. And her systolic blood pressure goes down to the 60s, her heart rate up to 110, mentally confused, of course. Maybe that was her baseline. But she was brought to the cardiac cath lab very emergently. And then you can see initially that's her initial presentation prior to her shock. Left main disease that was fixed, the beautiful results, everything looked good. And then the patient comes back, and that's when she was in shock. Large thrombus, in her left main LAD and the origin of her circ. And clearly a very sick patient. The ejection fraction in this patient actually was about 30%, 35%. Wasn't terribly bad, but she was in profound shock at that point. Impella was utilized, and the procedure was carried on. I'm not sure if I can show that again. And as you can see, the results were excellent. The flow was restored both to the LAD, the left main and the circ. All that thrombus has been removed. So patient hemodynamically was stable. She went to the ICU, and we were planning to keep her Impella for a while. We did not know when her blood pressure is going to recover. Interestingly, her left leg became more ischemic, and we decided that the Impella needs to be taken off. And we did. Over 2 hours, the device was removed, and FemStop was used for manual hemostasis. She did really stay hemodynamically stable. Unfortunately, you just couldn't keep her alive. And she ended up dying from sepsis from her bowel surgery. So she died with a good heart. That's all we can say. Unfortunate case, but shows you that the immediate and quick recovery of this patient was, from a cardiac standpoint, was so fast, and in fact, even with the Impella being removed within a couple of hours, she maintained stability without inotropic support. I mean, Impella we use is the Impella CP. You've already heard quite a bit about this. You remember she needed the sheath needed for the Impella CP is 14 French, providing, however, a very good blood flow, 3.5 liters per minute, which of course allowed us to do this procedure, allowed the hemodynamic stability during that procedure. Just a couple of things I want to point to you is always be aware of the anticoagulation with the Impella CP or any of the Impella device. Maintain, usually the ACT have to be well maintained, into over the 250-second range during the implantation. Make sure that the ACT until explant is at least between 170 to 180 seconds. One mistake I see happening is many times the Impella gets started before actually the placement guide wire is removed. Don't do that, otherwise you'll damage your Impella. So not to go over all this in details, just to tell you the extent of this problem, this is not a problem that is going away. This is a problem that is actually going to stay with us. And as you can see, this is a data from the British Cardiovascular Intervention Society from 2005 to 2010. And as you can see, the ACS patient presenting with significant shock is actually on the rise, believe it or not. And it doesn't matter if you're a male or a female. That also applies. And if you're over 75 or less than 75, that continue to be a problem. If you're over 75, you probably have a higher risk in that situation. So complex intervention with cardiogenic shock is not going away. In fact, it's actually increasing. And that makes it even more important, to train all our fellows and, and have them actually be tuned up to those complex complex cases. And by the way, they always happen when you're on call. That's just the way it is. And so everybody has to be ready for it. If you look at what have we done so far to affect prognosis, not too much. It's really pathetic. When you look at this, mortality is still in the 30 to 40% range. Over the past 6 years during that course of that study, from 2005 to 2010, whether it's at 30 days, 90 days, or at 1 year, we continue to see a very high mortality in treating those patients. And again, if you survive probably the first few hours, maybe the first couple of days, definitely if you survive your first 30 days, chances are you will survive, but mortality remains very high, almost in the 40%, 50% range. Again, if you look in the shock trial, it's very clear that if you leave the patient with a reduced TIMI flow, if you have an elderly patient, or if you attempt a conservative management initially, you're going to have a worse outcome. And again, that's early revascularization versus initial medical stabilization, and you can see the early revascularization is absolutely important in these patients. So again, if you look at the registry with percutaneous LVAD with the Impella 2.5 in cardiogenic shock study, it was published not too long ago, and you can see the data is very, very dismal. In fact, sadly, if you look at the survival, it was about 28.3% at 5 years. In fact, you can see beyond even the first 30 days, you're seeing mortality already in the as high as 70% in these patients. However, the good news is if your patient comes early and the lactate level is still on the low end, that means they didn't have that prolonged cardiogenic shock and that profound shock, the chance of survival is a lot better. And also if your patient have not received the CPR, their chance of survival is also better. That's all good news. If your patient is also less than 75 years of age, like we have seen in some of the early cases, chances of survival is also good. And again, early revascularization is extremely important in those patients. So again, about multi-vessel PCI in that setting versus not, I think this has been exhausted by the prior speaker. Bottom line, this is a study done in France, and as you can see in this study, people who presented with multi-vessel disease and shock had a worse outcome. But again, if you treated the multi-vessel multivessel PCI, you can see that multivessel PCI led to a better outcome, than a culprit PCI. Why Impella and PCI of complex disease and cardiogenic shock? Very significant hemodynamic stability. This patient that we did, her pressure was in the 60s. Shortly after you put the Impella, the pressure is in the mid-80s to low 90s, allowing you to do a lot of things without having to rush, in these particular treatments. So it gives you the chance to fully revascularize that patient. Again, I believe this is going to become a standard in, in treating those patients. We know intra-aortic balloon pump is probably not going to be sufficient. In a cardiogenic shock situation, the Impella CP is the one that we currently use. So again, promptness of revascularization is also critical for best outcome. And I think that's my last slide. Thank you very much.